Okay, it's 3:30, so I'll get this party started. I'm Martha Nowak with K-12 Engagement. We're glad you all come here to K-State Olathe. I handed out a little circular on our open house for next Saturday, so a little plug for us. Hope to see back here enjoying the activities that are planned. Today, however, we have a continuation in our Vet Med lecture series. So whether you're planning on becoming a veterinarian or you're just here out of just a gnawing interest, we're glad you're here. We have Dr. Raelene Wouda. Did I pronounce it correctly? No.
Well, it's fine.
All right.
It's like Yoda, but with a W.
Yoda. All right. Dr. Raelene Yoda. All right. Well, I will let you give us a little background on how you got your started, or if you've already put that into your lecture, that would be great. So join me in welcoming Dr. Yoda.
Hi, everyone. So this afternoon's presentation will be relatively casual. So if you have any particular questions or anything as we go through, feel free to just interject and ask away. Otherwise, what I'm going to talk about today, I've kind of split the presentation into two parts. The first thing I'm going to do is give you a little bit of background as to how I ended up here in Kansas, because as you can probably tell now that I've started speaking, I'm definitely not American. And then the second thing I'm going to do is give you a bit of an outline on what my current position at K-State involves and what I tend to do on a day-to-day basis. So my career so far has gone from Australia. I grew up in Brisbane, which is on the, I can't even see this laser, which is on the east coast here. I went to veterinary school there. I did an internship there. I did a residency there, but I've also worked in the UK as a locum. I worked in Philadelphia. I've worked at the University of Wisconsin. I've also worked in private practice back in Southern Australia, and now I'm here at K-State. So my path getting here was a little bit convoluted. And so the very first position I had that was veterinary related at all was a volunteer position in a general practice back home in Brisbane. So this was a practice that did your average stuff: vaccinations, spays, ear cleaning, the occasional orthopedic surgery, and looking after sick dogs with pancreatitis, etc. And I spent most of my time cleaning cages and doing the washing and mopping the floors. And I did it for free until they eventually started to pay me because I spent way too much time hanging around and they like to regulate my hours. It was a fantastic experience for me. And so for any of you who are seriously interested in a career in veterinary science, I recommend getting as much practical experience even prior to veterinary school that you possibly can, because working here, and I stayed working here, I started working here before I was accepted into veterinary school, and I stayed working there right throughout veterinary school. During all of those preclinical years where all you're doing is memorizing anatomy and learning all the physiology and things like that, having some sort of practical context to put it into, to know where you're going to end up using this information, was so incredibly helpful. And I also worked with a couple of the most amazing veterinarians at this practice, who I'm still very good friends with, and who were some of my strongest advocates, etc., when I was applying for veterinary school. And then I got into veterinary school, but this was eventually. Back in the day when I was applying to veterinary school in Australia, you could actually still get into it straight from high school. So it's a different system in Australia to what it is here. We don't have the whole college system like you guys have. However, having said that, only about 10% of our class ever got in straight from high school because it was so incredibly competitive. So most people that were being accepted into veterinary school had done at least 1 year of a bachelor of something, usually science. If not a whole degree, and then they were accepted into veterinary school. And so I didn't get into veterinary school straight from school. My marks weren't quite high enough. And so I got into science and I did a year of science, and to be very frank, didn't apply myself particularly well, despite the fact that at that time I still had in the back of my mind that veterinary science is what I wanted to do. And then from there, I sort of changed track a bit, and I actually went into a dual degree with science and arts, and I was doing English and journalism. And I essentially finished that major in journalism. And that was when as I was finishing that was a couple of years later, it was when I decided that I still wanted to do veterinary science, and when I got the job at Marshall Lane. And so in order to get into veterinary science, I realized, looking at my marks and my academic transcript, that I really needed to boost my marks up as much as possible, and I would do that by doing an honours program, which is essentially equivalent of a master's program here. And so to get accepted into an honours program, what I did was pick the subjects that I got the highest marks in, which happened to be art history. And so I have an honours or a master's in art history, which has no relationship to anything I do today at all. But I did that to get into veterinary school, which I eventually did. And once I was in veterinary school, things went a lot smoother. And I graduated from veterinary school with honours and went immediately into a rotating internship in private practice. You have a lot of different paths that you can follow from veterinary school. You can immediately go out into practice as a general practitioner. You can go out into practice working for the government in the public service, and making health-related policies and things like that, with a bit more background and experience. But you can certainly pursue a more specialty track, and this is the starting point to doing that. Straight from veterinary school, you can go into a rotating internship. You can do them in private practice or in an academic environment. And what they are aimed at is exposing you to a variety of different disciplines, specialty disciplines, that you can then pursue. And they tend to rotate you through, depending on where you're working, at least through the surgical service and the internal medicine services of a practice, as well as whatever other specialties they have there, as well as using you for overnight emergency shifts. And so that's what I did, and I did it in a private practice that also had a dermatologist on staff, had a cardiologist that worked part-time there on staff, and they had an oncologist that worked there on staff. But my actual intention in doing this internship was actually to pursue specialty in internal medicine. But having done about half of that year as an emergency clinician, which meant spending most of my nights awake and most of my days awake as well because I couldn't sleep, I was relatively tired by the end of the year. And so I took some time off, essentially, and I travelled to the UK. And my plan was to locum there, so to do relief work, and that's what I did for about half of the year that I was over there. So I hopped from practice to begin with, doing a week here and a couple of weeks there, until I finally was offered a more permanent locum position down in Brighton, here, which is on the south coast, which is a really, really pretty part of England. White cliffs and all run along there. But in between working in these general practices and learning how to handle pocket pets that we don't have in Australia, like gerbils, I'll tell you a story. In Australia, excuse me, in Australia, chinchillas are cats. They're a breed of cat. They're a big fluffy white thing with sort of silver-looking points on them. And at one of my locum positions, I had a chinchilla on my booking schedule for that day. And I was like, oh, that's nice. I haven't seen one of those cats as a breed for a while. They're not that common. And the nurse brought in, being the carry case, and it looked like a normal cat carry case. And I opened it up and I swore, because it didn't look anything like a cat. It looked like a funny looking large mouse with really big ears, and it was quite odd. And I turned to the nurse and went, what is that? She said, it's a chinchilla. And I'm like, oh dear, I need that pocket pet book again. Because in Australia, we don't have a lot of those. In fact, it's even illegal in most states in Australia to keep rabbits because of the problem that we had with them destroying grazing land and things like that. So that was a learning experience for me. And I spent about a year over there, and in between times I travelled which is also fantastic. And then towards the end of it, I was actually offered 2 jobs, one to stay in England and another one from a private referral hospital back home to do a residency in internal medicine. So that's what I ultimately decided to do. I'd spent a little bit of time my final year of veterinary school working at this hospital on the weekends with these guys. It was only the second private referral hospital to open up in Brisbane, and it grew very, very rapidly. It went from being a 3-vet hospital to about a 15-vet hospital in the space of only about 6 years. And so they've been very, very successful. But that was the team when I was there. And this was, a residency is basically your next step along the specialization pathway. It tends to be a 2-year or a 3-year, or even in some cases a 4-year program where you work in your particular area of interest underneath mentors. Usually 1 or 2 are actually required by the governing bodies that actually will ultimately declare whether you're good enough to be a specialist or not. And the idea is that you see cases that are relevant to your specialty, you read journal articles, and you study and gain experience in all of the procedures that are relevant to your specialty. And at the end of it, you sit exams and hopefully pass them. So my interest had been internal medicine, and so that's what I did this residency in, and I worked here for 3 years. And in Australia, like here, the specialty process for internal medicine at least has an exam partway through and then another exam at the end. And so that's the one partway through, and then change course again at the end of it. So these were some of my cases though when I was there, just to give you an idea of the breadth of things that internal medicine covers. So little Maytag up in the corner has to still be one of the cutest patients I've ever had. You know, you can never pass up on a puppy. She, however, was really quite unwell. She had pneumonia, really quite sick, and we don't know what the inciting cause of the pneumonia was in the end. But basically it was so severe that it caused a build-up of pus basically in her chest cavity. So you can see that she had oxygen tubes in, and she also had tubes going into her chest so that we could drain the purulent material out and put in, you know, sterile material, flush it around basically. We did tip her backwards and forth, a bit like a washing machine, and then suck it back out again. And she was in the hospital actually for a couple of weeks, so we did get quite attached to her. But ultimately, with lots of antibiotics, etc., she got better and grew up to be a very healthy little Vizsla. So that was always a good story. Willow, so the kitty at the top, is a Rex kitten who had the misfortune on the Gold Coast to eat a pufferfish. Yeah, which actually results in paralysis. It is a temporary paralysis, but it paralyzes them from the legs up and it paralyzes the respiratory muscles. And so unless you actually get them very quickly to a situation where they can be on a ventilator, animals that eat pufferfish will pass away. So Willow was with us on a ventilator for nearly a week, but was then weaned off. And this is Willow on the day she was going home. And then down the bottom is Kira. Kira was a really interesting endocrine case. So that's kind of the study of, you know, hormonal conditions. And she had Addison's disease, which is a decrease in the hormones that are produced by the adrenal gland. And what that causes is incredibly bad gastrointestinal tract signs and vomiting and diarrhea and weight loss, etc. As you can see there, she doesn't look that skinny. So this is well into her treatment. But in addition to that, when we started her treatment, she had a very strange cardiac side effect that was reported in people. But this was the first time it had actually ever been seen in a dog, where she actually went very briefly into cardiac failure as a result of reversing her disease process too quickly. She obviously got over that as well. These are all pretty good stories. This is Cujo, which is potentially the most ironic name that I've encountered. Doesn't look anything like the dog out of the Stephen King. Cujo came in because he decided to eat the pig ear treat, you know, those ones that are about this big. I think that's slightly bigger than he was. and it had got stuck in his esophagus. And so as the internists, we operate the scope material, so that's what we did. We put a scope down and pulled it out, but it had actually been there. Joe had been vomiting for quite a few days by the time we saw him, and it had actually damaged and perforated through his esophagus. So the following day, he actually had to have surgery to repair his esophagus as well. And just like Maytag, unfortunately, he also had at one point a chest straining because the food had gone from his esophagus, or the contaminated material had gone from his esophagus into his chest cavity. But once again, he got better and went home to his very happy parents. And this is Princess. Princess is one of my oncology cases that I had there. She had a splenic tumor, and most splenic tumors are disastrous. But it turns out that she had a rather benign form of splenic tumor, which made her a much happier story in the long run. But as an internal medicine resident back in Australia, about probably 50% of the cases we actually saw were oncology or cancer cases. And the reason for that is there were no medical oncologists in the state that I was working in. There were 2 surgical oncologists. And in fact, in Australia alone, even today, there are only 11 medical oncologists, which is not a lot when you consider the size of Australia and the pet population. And that was ultimately part of, I guess, my thoughts in pursuing further training. So I got to the end of my residency, and I was not quite ready to sit my exams because having done a residency in private practice, it's a lot of cases and not as much time off to study, which is a bit different from an academic-based one. And so my thought was to just do a little bit of additional training, and I actually applied for a job at the University of Pennsylvania. And there, the position was a fellowship in hematology and transfusion medicine. So administering blood transfusions to dogs and cats was certainly something that we did moderately frequently as part of our internal medicine program back in Australia for a variety of different reasons, trauma being the main one. But certainly sometimes in dogs with splenic masses that rupture, they need blood transfusions. For puppies and kittens that get flea burdens that are enormous, they can need blood transfusions. And then there are a variety of different disorders that can affect the bone marrow, cause severe anemias, and those patients as well can need blood transfusions. Anyway, so I ended up in Philly. The position was a year-long position, and what that involved was a couple of different things. Philadelphia has one of the very few animal-centered blood banks in America, and it was actually the first animal blood bank that was ever established. And very fortunately, they actually have a bloodmobile, just like the Red Cross do. And so their blood bank is entirely volunteer-based in terms of the dogs. They also have resident cats that live in this huge space with toys and things that they use as their cat owners. But their dog program is volunteer-based. Some of the volunteers, the owners will bring them into the hospital for their blood donations every 3 months or so. And then a couple of times a week, sometimes the bloodmobile will go out either to veterinary clinics or to pet stores or to breeders' locations and collect blood from screen donors there. So my job when I was there was to supervise this donor program. So that basically included screening all the potential donors. So the owners of the dogs that were donors had the ability to have them screened on a yearly basis for diseases such as heartworm disease, Ehrlichia, Lyme disease, anaplasma. So it's just general blood screening, like a CBC and a chemistry, a urine sample to make sure that they were healthy. And as a result of that, then they made a commitment that as long as their pet remained healthy, they'd be happy for them to donate relatively regularly, through their, middle adult years. So the dogs had to be at least 2 years of age. They had to be less than 8 years of age. They could donate only a couple of times a year, perhaps, if the owners wished. But that was the arrangement. And on top of that, the owners were given dog food was donated to by some of the pet supply companies. That worked really nicely, and the dogs were always the dogs had to be happy doing it as well. So the nurses there were a really unique group of people to work with, and if the dogs were too stressed to donate, because no sedation was ever used or anything like that for them. So if they were too stressed to bounce up on the table and just sit there and eat food while they gave a blood unit, then that was it. You know, they weren't going to be donors. And we always did a practice run at their first donation, so they never actually gave blood. They just hopped up on the table and got a great big meal and then went home again. So we babied them a bit to make sure that they were pretty comfortable with it. But my job was to make sure that their health was maintained. So to check the blood work on a yearly basis, to check the animals before they donated, to check the animals after they donated, make sure we were happy that, you know, the donors were being looked after. My job was also to look after the blood products and to supervise the blood bank itself. Essentially, it was run on the same principles as human blood banks. So you saw the fridge on the other side. It's a human blood banking fridge. Has an alarm on the door if you leave it open. It has an alarm that goes off, usually in my pocket, if the temperature or the power fails for whatever reason, so you know what's going on. And so with all the units of blood that were donated, there's only a certain time you can keep them. They would get turned on a daily basis. They're typed, just like human blood is typed. So dogs and cats have blood types too, not the same ones as us, but they do have them. And so these would be matched with, you know, the recipients. So that was another aspect of my job, to make sure that the blood products themselves were looked after. And then the third component of my job there was to look after the patients that received the blood products. And so the first part of that was to do all the blood typing for the patients and match them up with the transfusion product that they were going to receive. So we would type them, we would also cross-match them. And then when they were getting the transfusion, I would supervise this and make sure that they weren't having any acute transfusion reactions. And what that mostly involved was monitoring just the patient's basic vitals. So respiratory rate, heart rate, temperature, those types of things, whilst they was receiving the transfusions. And to make sure that, you know, the volume that they were given was appropriate, that we didn't underload them or overload them, etc.
Now, how long does it take generally to do a transfusion?
Okay, the time limit is a little bit practically determined. So we won't have the blood units out of the actual refrigerated for more than 4 hours, because we always worry about contamination. And so we would determine the volume that we were going to give a patient based on what their actual red blood cell count or hematocrit was. And then we would determine what our ideal level was. And from that, based on the weight of the patient, we can calculate how much blood we want to give. And then we would usually endeavour to give that over the 4 hours. So we would divide the volume, you know, by 4 hours and to work out what a rate per minute was. But it does depend on why we're giving the blood. So for example, in a trauma situation where the blood loss might have been very, very acute, we might actually give the volume of blood actually a lot quicker than that. So it depends, but 4 hours is usually the limit we would do. And if the patient is stable enough to have it administered over that period of time, that's probably safer from a monitoring for, I guess, reaction situation. And we always start them off a little bit slower. So we'll run them very, very slowly at the beginning and then go up to a standard rate after about 10 to 15 minutes. And whilst I was there, I kind of reassessed, you know, what I wanted to do the year after. And I was really enjoying working in the United States, and I was really enjoying working in an academic environment. And I made the decision that I would at least apply to do a residency program in oncology. And the reason I picked oncology was, I guess, what I mentioned earlier, in that thinking about going back home at some point in time, my thoughts were, what additional thing could I learn whilst I was over here that would complement what I'd already done and would be a benefit to my patients back home. And oncology, we saw so many oncology patients, and with, I guess, not a lot of oncologists back home, that kind of made sense. So that's what I did. I applied for oncology residencies and couldn't believe my luck when I got one at the University of Wisconsin. That school is one of the most amazing oncology programs that you can get accepted into. That in Colorado, nothing against K-State, I love K-State, but those two schools, back 15, 20 years ago, were the leading schools in terms of developing veterinary oncology chemotherapy protocols. They're leading schools in terms of technology, etc. still today. So I burst into tears when I found out I got my residency. So I went there for 3 years and, switched from supporting, the Eagles to supporting the Green Bay Packers. I like the Packers better. And, we're in Kansas now, and I'm allowed to keep supporting them because Geordie Nelson's family lives just down the road. And I loved my oncology residency. My actual intention was obviously still to go back home and to use what I was learning as part of my broader internal medicine practice. But partway through my oncology residency, I really realized that, once again, my idea of what I wanted my career to be was changing again. And I liked the specificity of the oncology program. It wasn't as broad ranging. And you could really focus on the absolutes that I guess exist a little bit more in oncology than they do perhaps in internal medicine. So oncology patients, we always have, always, it's a little bit of a general statement, but we tend to have a definitive diagnosis. And it's hopefully one disease, although some of these patients are a little bit older, so they do sometimes come with some other concurrent disease. But usually the cancer that we're managing is their main disease, which means that we can focus on that. And in terms of doing studies and investigations that answer whether treatments are beneficial or not, it's easier in oncology, to be frank, than it is for things like internal medicine, because we can focus on a disease, pick a treatment that we want to investigate, and check whether that treatment works in that subset of patients. And they tend not to be affected by anything else, and usually we can investigate just one treatment at a time. With internal medicine cases, there's a lot more grey, and I guess that's why oncology, to a certain extent, appealed to me. And so I finished my residency, and I sat my American exams and passed those. But I did go back home. I contemplated staying in the United States, and the idea of working in academia definitely appealed to me. But those positions are a little bit hard to come by. And so I ultimately decided to take a position back home in Melbourne, Australia, in a private referral hospital with Charles up the top here, who'd actually, he's American, he did his training at Colorado State University, and he was a surgical oncologist. And there were other specialist surgeons that worked at the hospital. But I, with my background in internal medicine and in my oncology background, that's what they needed to build their practice. So I went there. And I was there for a year, and it was a great year, and it was a very busy practice, and it was nice to build up, I guess, the medical side of it. But I missed working in an academic environment. I missed teaching, and I kind of missed being over here, and I missed the environment that's so collaborative in America when it comes to oncology. There are some very well-established organisations that promote research, etc., over here compared to perhaps Australia. And so I missed that. And so a little way through this year, I applied for this position and then was offered it and ended up back here at K-State. So I've been at K-State now for only 18 months. So not an extraordinarily long time. Certainly not long enough in America to completely lose my accent. But I'm really enjoying it. And the reason for that is that what I do at the moment is so varied. So I have a role So my position is tenure track faculty. I'm an assistant professor. My appointment is basically 50% clinical work. So I work in the hospital on the clinical floor with our oncology patients and our clients. And then 50% research and teaching. And the teaching varies. The teaching varies a fair amount. The majority of what I do is actually for the seniors when they're on their final year and they're spending all of their time on clinics and they rotate through the different services. So they'll rotate through internal medicine, they'll rotate through radiology, surgery, they can rotate through oncology. And so we have students on our rotation working with us in the clinic almost every week of the year. And so we're teaching them in that sort of clinical environment. On top of that, I lecture to the juniors. I think I've got my terminology right because we don't call anybody back home juniors, seniors, sophomores, or freshmen. So I think it's the juniors. Anyway, they're the third year. Yeah. Yeah, got it right? Good. Yeah. So I teach the oncology course to the third years. I teach a few practical laboratories during the first and second years. And then we also have our graduate students. So we have an internship and a residency program here at K-State for the oncology service. And as part of their residency, the residents do a master's program, a project. We also, Dr. Higginbotham and myself, the two oncologists there, are also on several PhD committees for PhD candidates. And then on top of that, we also have some undergraduates that come through the school. There is a pre-vet club at K-State, and we have some of them come through. But on top of that, we have a lot of undergraduate students that apply for the summer scholar program. So these are short-term projects that occur over the summer where the students are allocated to a project group depending on their abilities and interests, etc., and they complete that over the summer. We intermittently, I guess, participate in that depending on what our schedule and projects are allowing for. And so the clinical cases. So I spend a lot of my time treating our patients and all, and these are all patients that we've seen at K-State relatively recently. And our clinical work is relatively broad. You know, we do a bunch of different diagnostic tests to get the diagnosis of the specific cancer we're treating. We do staging tests then to determine where the disease is in the body. And that can include anything from chest x-rays to abdominal ultrasound, to CAT scans, to MRIs, and biopsies as well if the abnormalities are not definitively, I guess, neoplastic on the imaging. And then the treatment options we have are just the same treatment options that we have for treating people with cancer. Surgery is always nice if it's an option, because if you can cut it out, that always gives you the best head start on therapy and a more positive outcome. And I'm a medical oncologist, so I'm allowed to say that surgery is a good option. We have radiation therapy, we have a LINAC at K-State, and then we can do chemotherapy. We use similar drugs to those that are used in people. There are very few veterinary drugs, and especially veterinary chemotherapeutic agents that are actually animal specific. In fact, there's only 2. So most of the drugs that we use are those that are used in people, and we use them off-label. Now, we don't use them completely blindly. We've done a fair few studies to establish the side effect profile of the drugs and the appropriate dosing of them in both cats and dogs usually, as well as potentially some of the smaller species and even sometimes some horses. And more recently, we have some immunotherapeutic options as well. Immunotherapy is a really up-and-coming area of interest and development in human oncology. It's probably going to be used to complement all the other treatment modalities that are available, and the same applies in veterinary medicine. So there's actually one veterinary anti-cancer vaccine that is currently registered for the treatment of melanoma, but there are lots of immunotherapeutic options that are in the works at the moment.
Can I ask, radiation and chemo, do they produce the same side effects as for humans?
It's a little bit different, and the reason for the difference is twofold. Historically, the treatment of people with cancer has been, I guess, to treat to get the best outcome for the patient, and that has perhaps been to the detriment of quality of life. And so, you know, they've given potentially very high doses of drugs, high doses of radiation therapy, with the anticipation of a cure or a longer term outcome, but the side effects therefore can be quite severe. In our patients historically, our approach has been the reverse of that. Owners of our patients have always been far more concerned with quality of life above perhaps the outcome. You know, and we can't talk to the, well, we can, we do it all the time, but they can't necessarily interpret and understand what we're saying. They certainly can't convey back to us that they understand it and that they choose to go ahead with therapy or not. They're also really good at potentially hiding the side effects. So we're terrible, we complain at the drop of a hat. You know, if we've got a sore tummy, we can tell someone. If we have a headache, we can tell someone. Dogs and cats, even from an evolutionary perspective, basically try to hide their symptoms. So if they look unwell, then they are really genuinely unwell. And so in establishing the doses and the protocols that we've put together over time, what we've tried to do is use doses and dosing intervals that certainly achieve a response, but whilst trying to minimize side effects compared to people. So our side effect rate for most of our protocols is about 25 to 30% of our patients experiencing side effects. And most of those are mild to moderate in that they might not eat for a day or so after their therapy, or they might develop some vomiting or some diarrhea. They certainly do have drops in their white blood cell count, but they don't plummet because of the doses that we give. And so it's a bit of a balancing act for us. The other reason we can't give as screamingly high doses that are used in people is the whole white blood cell count thing, basically. You know, if we, you know, ablate the bone marrow like is often done in people that are receiving cancer therapy, so that they have, you know, no ability to regenerate without a bone marrow transplant, then that is not something we can do readily, because doing bone marrow transplants in our patients is challenging to say the least. It's not that it can't be done, it's just finding appropriate matches to the typing is very, very difficult unless you happen to have, you know the breeding history and have a relative of the actual patient. And for a lot of our patients, that doesn't exist. And even then, the typing is quite complicated. There's very few places that do bone marrow transplants for dogs. North Carolina is one of them. And the research that's published to date for dogs with lymphoma, at least, don't show a huge advantage in combination, you know, with chemotherapy. And so I guess that's why it hasn't really taken off and been, I guess, more aggressively pursued so far by us as oncologists.
Do they lose their hair?
Right. No, mostly, I mean, most chemotherapeutic agents that we use target rapidly dividing cells. And so that's what cancer cells are, to all basic intents and purposes, are cells that are more rapidly dividing than a normal cell, surviving longer, etc. But there's a couple of places in the adult body where we have rapidly dividing cells normally, and that is the gastrointestinal tract. That's why you get the vomiting and the diarrhea, because you knock those cells out. The bone marrow, and that's why you get the tanking white blood cell count. But also in people, the hair follicle, we have continuously growing hair. And that's why people that are undergoing chemotherapy and radiation therapy often lose most of their hair. Dogs, some breeds do, but most dog breeds do not have a complete continuously growing hair coat. Most of their hair follicles are actually in a resting stage at any given point in time. So most dog breeds, like your average Labrador Retriever or Golden Retriever or what have you, might shed a little bit more, but they certainly don't lose their hair coat. Now, some breeds, like Huskies, that go into a growth stage seasonally, depending on when you give the drug, may lose a significant portion of their coat. And some of the terrier breeds can definitely lose a significant portion of their coat. But I've never seen a dog go completely bald. I have seen a white poodle grow back apricot hair though. So yeah, it's like you have a new dog. So the side effects we see are kind of similar, but I guess they're of a lesser extent in our patients because of the, I guess, slightly more conservative way in which we use the treatments that we do use. The good thing about that is most of our patients that receive chemotherapy bounce in and out of the clinic, on a weekly basis, looking perfectly happy. The downside of it is the outcomes. So, for example, for lymphoma in people, for a non-Hodgkin's lymphoma, the cure rate can be approximated at 50 to 60% with aggressive therapy. Now, we get a very, very similar disease in dogs, where all their big lymph nodes go up and things like that, and we treat it with really similar drugs. But instead of giving all the drugs all at the same time and at high doses, we space them out a bit and use them at slightly lesser doses. So we get a really good remission rate. It's actually 85 to 90%. It's just that it doesn't last as long. So our survival, overall survival, is probably only about 3%. But the average time from diagnosis is, say, 12 months, with 20 to 25% of dogs surviving another year after that. So we get really good responses with doing it the way we do it. It's just not quite as good as perhaps being slightly more aggressive. That was a long detour. But anyway, so clinical cases. So we do essentially the same things as they do in people with cancer therapy. And then the other thing that I do is research. And there's lots of different ways that research can be done. It can be done sitting at a benchtop in a laboratory. But what we mostly at K-State do is run a clinical trials program, where what we do is take information that's provided to us by our benchtop researchers. They may have developed a new molecule that can be used to potentially treat cancer. They may have developed a new diagnostic test that might be more sensitive and specific at trying to pick up cancer earlier. And so we take that information from them and we try to put it into a clinical situation and investigate it in our actual patients. And vice versa, we can actually take the information from our clinical patients and take it back into the laboratory to complement investigations that are going on in the laboratory. And we can also take the information we get from our patients here back into investigations into human cancer as well. And that can be used to complement studies in human cancer. And I have a couple of examples of clinical trials we have going on at K-State at the moment, just to give you an idea of, I guess, the differences in the scope of what we do. So the first one is a phase 1 study. We were looking at just what was the safety profile and the tolerability of combining 2 chemotherapeutic agents together, one of which was Palladia, which is a relatively new drug. It's more a molecularly targeted agent and using it in conjunction with carboplatin, which is one of the more conventional high-dose injectable chemotherapeutic agents. And what we were trying to decide was, we know the adverse effect, the side effect profile of both of these drugs when they're used individually. This one, carboplatin, causes both tummy upsets, but mostly causes bone marrow suppression more readily than it does tummy upsets. Palladia probably causes tummy upsets more than it does bone marrow suppression. So there's an overlapping toxicity profile there, but each of the drugs hedges in the opposite direction. And the reason we wanted to know what their tolerability would be when we use them together is because they have such different mechanisms of action that if we use them together, then we can potentially have synergy against treating some of the diseases. So this was a pretty conventional study design that we set up, where we designed it with 3 initial cohorts. So we started off with a lower dosing of carboplatin, and the plan was to enroll 3 dogs at that dose, then go up to the next dose, providing those initial 3 dogs tolerated the drug combination okay, and then from the next dose to go up once again to the next dose. And we started with a standard dose of tazarine. And the reason we decided to escalate the carboplatin rather than the Palladia was because we've done similar studies with Palladia and other injectable drugs previously, and it was always the other drugs that needed to be de-escalated to begin with, rather than the palladia. So we had to use that and made that assumption in setting up this trial. And for this type of clinical trial, where it's simply a tolerability study, we can take dogs with pretty much any cancer type. And obviously there's a preference for dogs with cancer types that we think might benefit from this drug combination. But we literally can include any dogs, and they can have naive, untreated disease, or they could have disease that happened to be progressive at the time. But what we needed was baseline so that we could monitor them. And they had to be relatively well. And we have grading criteria for that. But anyway, so this was pretty much almost the first patient that was enrolled. This is Clarence. He's a darling boy. He's a 9-year-old castrated male. He's a retriever cross. Doesn't look much like a retriever in that picture or in real life, frankly. I mean, he was initially presented to us because he had a mass that the owners had noticed here in his neck. And so what we did originally to diagnose him is what we do with most of our oncology patients, which is actually just to stick a needle in the mass, suck some cells out, stick them out on the slide, not literally, and stain it and have a look at the cells. And this is what Clarence's cells look like under the microscope. And that's a fairly typical appearance for a neuroendocrine or a hormonally based tumour. And in this region, the most common tumours in dogs that are hormonally based are thyroid tumours. Luckily in dogs, they're usually non-functional, so it's really the space occupying effect and the fact that over time, these are a malignant tumour, they will spread, they will metastasize. Ideally, the therapy would be surgery, but the minute they get past a certain size in this anatomical location, surgery becomes very difficult because you have the jugular vein, you have carotids running through there, you have some very large nerves, esophagus, trachea. It becomes quite difficult once the tumours are past a certain size and quite fixed. And that was unfortunately the situation for Clarence. This is his CT scan at the time of diagnosis. And this is the tumour. You can see it here. Sitting right beside, this is his airway, this is his windpipe trachea with the tube in it while he's under anaesthesia to have his CT scan. And this is his brain and all up here. So this is the tumour originally, and you can see it's wrapping around there and pushing a lot of the normal anatomical structures aside. And usually you would be able to see his esophagus as well as his trachea here, but it's actually being obliterated by the tumour currently. And so given that he wasn't a great surgical candidate, the owner elected to have him enrolled in our clinical trial. And he was one of the first dogs, as I said, so he was in the first cohort at the lower dose, and he did really well. He had virtually no side effects or anything from the drugs, no tummy upsets, nothing. And even better, he had what we could classify as a partial response to therapy, which means his tumour shrunk by 30%. And so this was his scan approximately 6 months after starting therapy. And you can appreciate that it's much bigger here than it is here. And as I was saying beforehand, I did have videos in here to actually show this clearer, but I couldn't get them to play repeatedly. This tumour on the side, actually, when you play the video through, it actually wrapped all the way around here. And that diminished significantly on the side here. And believe me or not, but this is his esophagus that we can now see here, and there's separation from the trachea here. So he had a really great response to therapy. And after the conclusion of the clinical trial, which was a set period of time for each patient, his owner chose to continue him on the palladia. And so this is Clarence quite recently. I emailed his owner last week to get an updated photo, and he's doing really well. He's actually coming into the clinic in 2 weeks' time for his next CT to see how he's doing. So the second patient that I wanted to talk about was Miss Lily. She's a 10-year-old female spayed miniature schnauzer. And she came in because she had a lump basically in her armpit that had been noticed by the owner. And so once again, we did what oncologists do, and we stuck a needle in it. And this time the cell sample looked like this. And you can probably see in these cells, there's a whole lot of pigmentation here. And this is what melanoma looks like on cytology. So that's what she had in her armpit. Now there's lymph nodes in that area. And so the question was, has this arisen spontaneously in the lymph node, which is certainly a possibility, but unusual, or had it spread from somewhere else? Now, the most common location for melanoma in dogs is actually not the skin, it's usually the mouth. But that lymph node down there doesn't drain the mouth. It's these lymph nodes here and the ones at the front of the neck. So we did chest x-rays, etc., and looked elsewhere to see if we could find a primary tumour, and we couldn't. And so, but there was a suspicion on her initial chest x-rays that she has kind of a feathery pattern through here. The radiologists were very concerned that that feathery pattern represented pre-existing metastasis in her. So given that she wasn't a surgical candidate, once again, her owners chose to enroll her. And she was one of the dogs that was enrolled as we went into the second cohort. And with her, her white blood cell count did drop significantly. She had what we call a grade 3 neutropenia. So her neutrophils became quite low, which would usually typically necessitate a dose reduction if she was a normal patient, as well as a course of antibiotics. And according to the clinical trial schedule, a dose reduction is applied. And so she went back down to the previous cohort level and continued through the clinical trial at that level with no further side effects. And her response throughout the clinical trial was her disease remained stable until the finished time frame. But unfortunately, at her recheck a few months after finishing the clinical trial, despite the fact that she actually continued on Palladium as well, but she had more definitive metastatic disease develop in her lungs, and you can see the nodules there. And then this is Scooter. Scooter, the last patient that's actually been enrolled in this clinical trial, and he's nearly finished, but not quite. And he presented with a perianal mass, basically, so had a butt mass, and it was enormous, like this, on this tiny little dog. So definitely not a surgical candidate. It was invading and involving the rectum, etc., and part of even the colon. But we did the same thing with him to diagnose it. We aspirated it, and it's a type of tumor called an Apocrine gland anal sac adenocarcinoma. And he, being one of the dogs in the second cohort as well, was once again started on that higher dose. But once again, just like Lily, he had a drop in his white blood cell count. So once again, went back on a dose reduction and is continuing through the clinical trial, which will finish on the lower dose. And he currently has stable disease based on measurements of his mass. So what we learned from this clinical trial is that we have a dosing recommendation when we want to use these drugs together. You know, we know we can't go as high as 250. The percentage of dogs that go that high, they all have white blood cell counts at 10, and we can't do that. So we know that we can safely give the dogs a 200 milligrams per meter square, and they'll do okay. So the next thing we want to know is, you know, what diseases, you know, can this potentially benefit? And we've already seen that Clarence has had a really nice response, and he had a thyroid carcinoma and it shrank. We also had a second dog with a neuroendocrine disease as well, whose tumour shrank. And so perhaps the next thing that we'll do is to establish a clinical trial that looks at thyroid carcinoma specifically and response to therapy with this drug combination. The second study that I wanted to mention, and I'm going to have to run through this really quickly, is a multi-institutional study that we're involved in. So the first one was just one we were running at K-State. This one is being run in conjunction with the NIH and the National Cancer Institute, and the COTC, which is a Comparative Oncology Trials Consortium. And what this is a group of academic and, in a couple of cases, private oncology practices throughout the United States that meet certain criteria and standards that then coordinate to do larger scale clinical trials that have more statistical weight. And so the aim of this study was basically to investigate the use of rapamycin or sirolimus in the treatment of osteosarcoma. There's been previous studies looking at the tolerability of rapamycin in dogs, and so this was the next step up, is the investigation of this drug and how we can use it potentially to help get better outcomes for dogs with this disease. And the aim of the study is it's a two-arm study. So we have an arm for the dogs that undergo standard of care therapy, which is actually an amputation of the limb that's affected by the cancer, followed by carboplatin chemotherapy. And that's been standard of care for a long time. It's very similar to what's done in people. And then the second arm, the dogs are going to receive standard of care therapy, but after the carboplatin course is completed, they're going to have ongoing rapamycin. And it's a more molecularly targeted agent. It's an mTOR inhibitor. And so the thought is that in the longer term, it can improve outcomes in the dogs. So just some background information on osteosarcoma in dogs. It's the most common bone tumor that we see in dogs. It mostly affects large and diet breed dogs, like Duke here. And you can see the lump on his leg where the tumor is. And mostly what these dogs present with is pain or lameness when they're walking. And sometimes the lump is palpable, but not always. They occasionally will have a fracture at the time of presentation, but certainly not always. And the reason why there's a lot of studies focusing on osteosarcoma, and the reason that the National Cancer Institute is specifically interested in it, is it's so very similar to the disease in people. So osteosarcoma is the most common bone tumor that affects pediatric, really teenage patients, and it's almost exactly the same as the disease in dogs. It occurs in the same anatomical location. So in dogs, the most common location is here. In people, the same is true, but in dogs, you can get it here and here. The same is true in people. When we look at it on an X-ray, the X-ray appearance is similar. When we look at it histopathologically, it looks similar. The clinical progression, and this is important, is similar. So it presents as a primary bone tumor, but it metastasizes to the lungs in both people and in dogs. And the response to therapy is similar. So in people, the treatment choice is, amputation or a limb-sparing type procedure, followed by chemotherapy, which is a platinum-based chemotherapy, and the same is in dogs. And the response rates and the durations, when you take into account dog years versus human years, are actually very similar. And what that means is obviously that if we investigate a certain diagnostic test with respect to osteosarcoma or a certain therapeutic option and it works well in dogs, then the odds are that it's going to have some benefit for human patients. And it will be able to be translated across into that field. And that's the actual aim of this study. Is if this works in dogs, the next step is to do it in human pediatric patients. And this is just an example of how similar it is. This is a mix of the genetic analysis of osteosarcoma in dogs and people, and the genetic signatures and the mutations. You can't tell the difference between the dog disease and the human disease. And so, as I mentioned, the typical approach to a patient with osteosarcoma is usually amputation in our canine patients. You can see these three-legged guys here. Sometimes we can do a limb-sparing surgery, but the only candidates for limb-sparing dogs are ones that have the tumor located here at their wrist. And then we follow up with a platinum-based chemotherapy protocol. And when we do this approach, the median survival time from diagnosis is about 10 months. So it's not brilliant, but it's certainly better than if they undergo no treatment alone. Palliative treatment, the median survival time is maybe 5 months. And amputation without chemotherapy, the outcome is actually only about 4 months. And so the thought is obviously that rapamycin can improve things. So this is the first dog we enrolled in this study relatively recently. This is Ernie. He is a darling, darling dog. He's a Great Pyrenees and he likes to live with his sheep flock. And he was very upset when the owners noticed he was lame, and then they put him in the barn and eventually the shed away from his sheep flock. And he was so incredibly upset and he looked very, very sad. So he came into us with the history of lameness and he did have a palpable mass. And this is his x-rays. They're not the most startling osteosarc x-rays that you've ever seen, but you can see that there's this lytic or darker lesion at the base of the bone here. And you can see on the lateral view, the side-on view of his leg at its radius, you can see this proliferation coming out from the bone, as well as some soft tissue swelling there. And that's pretty typical, but sometimes it's a lot more like effusive than that, or proliferative. Usually as part of the workup, we do chest x-rays, make sure the chest is clear of metastatic disease, and for the clinical trial, we also had to do an abdominal ultrasound, and we had to diagnose that it was definitely osteosarc, and we did that by doing aspirate of the lesion with some local anesthetic on board, because popping a needle into the bone hurts a bit more than it does popping it into just a skin mass. And he was confirmed as having osteosarc, but hadn't spread anywhere else, so he remained a candidate for the trial. So he underwent his amputation, and then 2 weeks post-amputation, he started his carboplatin chemotherapy, and he's just finished that, and he was randomized to the rapamycin arm. And so he's about to go and start his rapamycin. And he's just been restaged at this point and is still free of disease currently. So he's doing very, very well, and he's much happier because he's back out with his sheep. And so, as I mentioned, the point of this study is that if this works, and there's already 68 patients enrolled America-wide in this study, if this works, then we're going to translate this information across into our human pediatric patients. So just in conclusion, I hope today, I guess I've illustrated to you a couple of things. One is, and it was a slide I glossed over at the beginning, but one is that any decision you make, or almost any decision you make, is not permanent. You are allowed to change your mind. I know it feels like every decision you make at this point in time is going to be set in stone forever, but you definitely should try to find something you love doing, and probably something you're good at. Usually those two things overlap, and to follow your dreams, but they're allowed to change with time. And it's not the end of the world if you go into something and it doesn't work out. I'm very glad that I changed my mind several times about what I chose to do. The other thing I wanted to highlight to you is if you are thinking about a career in veterinary medicine, there are a lot of different options. You can be a clinician and you can do that as a general practitioner or as a specialist. You can do it as a large animal practitioner or a small animal practitioner, or both. You can do it as an exotic or a zoo medicine veterinarian. You can work in academia or private practice. And then you can do other things. There's pathologists and radiologists. You can be a teacher, a researcher. You can work in industry or for the military. You can work in government. You can work from a global health perspective. And there are veterinarians now working for the National Cancer Institute on the whole idea of this One Health perspective and the fact that animal health is often a reflection of human health in an environment, but animal health on top of that and investigations in animal health, like the Osteosarcoma study, can be taken and those results can be translated back in order to improve human health. And things like food supply medicine and things like that. So it's a very broad ranging career choice that isn't necessarily confined to simply playing with puppies and kittens. In fact, most of us don't do that. And as required, there are all my acknowledgements for my funding sources and collaborators. And at this point, having rushed through it, I think I almost finished on time. Any questions? Yeah.
When you first started speaking, tell us what age you were when you first started cleaning out things and so forth.
I would have been, let's see, I finished high school at 17, so 18, probably 21, 22.
Was there any rule about what age you had to be before you'd be allowed to do that?
There is, I mean, there's laws at home as to whether you can work or not, and I think the age is 16 or 14 with parental permission, and that was not my first job. I worked at a shoe store. I was really good at selling shoes. Yeah, so I mean, by the time I volunteered there, but I worked there, right, as I said, like I worked there right through my veterinary course. And it took me a couple of years to get into veterinary school, as you may have gathered. So we had high school students come through there to just do work experience type blocks. We had some that did some volunteer work. And there were quite a few, volunteers that came through, and other people that started as volunteers and then stayed on as nurses and things after that. So I started there cleaning and mopping cages, but by the time I was finished there, I was working as a receptionist / unqualified, veterinary nurse and running anesthetic machines and all. But I worked there for, it was 8 years. So, but it was invaluable. And there was some overlap there. So, I worked there right through veterinary school, but as I mentioned, I did some weekend work at a specialty clinic as well during my final year of veterinary school. So I did a little bit of overlap and gaining some experience.
We do have another question from Blue Valley Caps. This is for blood donations. It kind of cracked us up that dogs are voluntary donors,
But the cats aren't.
Cats aren't.
Yeah, the cats, running a volunteer cat program is a little bit more difficult. I don't know where to talk now. Running a volunteer cat program is a little bit more difficult because a lot of cat patients are not going to be as obliging as your average golden retriever. And the cats do require at least Valium level sedation for the collection of their blood product. And also because cats, in terms of monitoring their disease and disease exposure, it can be a little bit more difficult as well. And so for that reason, UPenn kept a cat colony. They actually had about 26 cats. They lived in an enormous set of rooms off the back of the blood bank that had climbing poles and windows and things like that. But only, they were SPF, so they were specially raised cats, and only the blood bank staff could go in there, etc. And they were only kept for a few years. The maximum, I think, was 3 years as a blood donor. So we got them as about 12-month-old cats. They were kept for a few years. They did their blood donation thing, and then we rehomed them. So that's how the cat colony maintained it. It was mostly for practical consideration regarding, I guess, maintaining the quality of the blood product that we got at the end, and also taking into account a cat's temperament in terms of donation rather than compared to a dog.
Any other questions?
Are there as many or more blood types in canine compared to human?
So there's, just like humans, there's 2 main blood types. So there's DHA blood types. There's actually 13 blood types in dogs, but most of them are minor. So we would test a dog for DHA 1 and 1.2. And we would also sometimes test them for a couple of the other minor ones, but we wouldn't test them for the whole 13. So it's a little bit like people in that respect, because people have the 2 main blood type, or the AB and ABO and things like that. And then we have RH blood types. But if you go looking at immunologic factors, which is basically what the blood types are, there's actually some additional ones in people as well. But technically there's 13 blood types currently recognized for dogs. But some of them are breed specific too. Dalmatians have their own individual type.
Any other questions? Blue Valley has already got all their questions answered.
Okay.
So if there aren't any other questions, I have on the back table your evidence of attendance, if you need that for your extra credit for your teachers. There's also a handout on a One Health course if you're interested in taking that this summer. I'll have it for 3 weeks, June 1st through the 22nd. So if you want information on that, there's a flyer there. But thank you for coming, and thank you, Dr. Wouda.